I would like to invite for this session on super interesting cases in the order of appearance Professor Dev Pahlajani, Professor I.B. Vijayalakshmi, Dr. Amit Vora, Dr. Sumita Chaudhary from Harvard, Massachusetts, and Dr. G. Galapati from Sri Lanka. Our only speaker as of now is Professor N.N.Khanna, who is the Senior Consultant Interventional Cardiologist and Vascular Intervention Consultant, and he is the Coordinator of Vascular Services at Indraprastha Apollo Hospitals in New Delhi. So in the meanwhile, as he presents his case, we hope to have the other presenters as well. So as per the guidelines of the scientific committee, each of the presenter would have 5 minutes, and then we'll take up 2 minutes of discussion. May I request all the delegates to kindly switch their cell phones to vibratory mode as a mark of respect to the speakers and courtesy to fellow delegates. And I would request Professor N.N.Khanna to kindly set the ball rolling. Professor Khanna, if you could please set the ball rolling. Thank you very much. Dr. Chaudhary, if you could please join Professor Vijayalakshmi on the dais. Thank you very much.
Good morning, everybody. Professor Khanna, you already know. He's next chairman for the NIC, and yesterday he delivered a beautiful lecture. So today he's the opening batsman. So let us hear from him.
Thank you, Dr. Vijayalakshmi. So I was allotted 5 or 6 minutes, but maybe I'll take more time because I've been told that there's no other speaker. Maybe present one more case. So this is a 67 years old gentleman who was a diabetic, had acute coronary syndrome, and ironically also had recurrent TIA. So he was a patient of acute coronary syndrome, an acute cerebrovascular event. And to top it up, he had a difficult arch anatomy. So we were in a situation at 2 o'clock in the night when we had to deal with both carotid artery stenosis and recurrent TIAs, and also acute coronary syndrome because of severe coronary artery disease. This was the arch angiogram. You can see it's a bovine arch, and there is a very difficult takeoff of the left common carotid artery. This is the coronary angiogram. You can see there's a high-grade stenosis in the OM1 bifurcation, and also a tight stenosis in the LAD just before the LAD bifurcation. The left right internal carotid artery, you can see, is almost closing down, and there's a big thrombus there. And on the left side, the vertebral was normal. Whenever we do carotid artery angiogram, we always do a 4-vessel angiogram to see the collateral circulation through the circle of Willis. So luckily, both the vertebral arteries were normal. And on the left side, again, there was a tight stenosis in the left internal carotid artery. So our option was to treat both the internal carotid artery stenosis and also coronary artery stenosis. And we chose to treat the carotid first because it's always better to treat the carotid first when you have both coronary and carotid artery disease. And here with this sort of stenosis and a thrombus in the internal carotid artery, it was prudent that we use a proximal protection rather than a distal protection. We didn't want to even wire this lesion without obtaining a protection. Our only concern was that whether the patient is going to tolerate the proximal occlusion or proximal protection, because the contralateral carotid was also occluded. But since both the vertebrals were good and dominant, we thought probably this would work, and this worked. So as we do the procedures under roadmap, and we go always through the radial route. And this is, we just did a wiring in the external carotid artery, and then took a MoMA device. This is a 7 French MoMA device, which we take from the radial route through a bare without a sheath. And then we occlude the external carotid artery and the common carotid artery through a balloon. And what it does, it reverses the flow through the circle of Willis, and the flow is now from the intracranial circulation down to the internal carotid and common carotid artery. And so if we achieve this, there is no risk of distal embolization. And once we achieve this, you can see there's a stagnation of the flow, and now after this we don't have to give any contrast, and we can go ahead and do the procedure with the guide wire of our choice. And here we chose a whisper wire because the lesion was very tight. Under the roadmap, with some difficulty, we could get a 014 whisper wire across the internal carotid artery stenosis. And once that was there, then we used a 2.5 millimeter balloon to just predilate, and we do not use a good predilatation in carotids, unlike in coronaries, because here the restenosis is not an issue. What is it? We do carotid artery stenting to prevent distal embolization rather than to prevent, to increase the flow. The flow is usually there because of the 4 carotids which are interlinked, but only to prevent embolization we do carotid artery stenting. And after that, we took out the stent assembly and aspirated. That's a very important thing. We always aspirate whenever we do carotid stenting through proximal protection, so that whatever debris is there, we just aspirate it out. And then we did a post dilatation with a 5 millimeter balloon. And this is the result which we got on the right internal carotid artery. After that, the patient was quite stable, and we thought we should go ahead and treat the left internal carotid also, because the patient was still having some sort of TIAs, and we thought let's go and do it. Although this is not a thing which we advocate in all the cases. Again, we took the same MoMA device and did a proximal protection. This time we were not concerned about the tolerance of tolerance of this device, because the contralateral carotid was now fixed. And then we went ahead and obtained a proximal protection and reversal of flow, and did stenting in the same way. After that, the STs were still high. ST elevation was there, and we went ahead and did the stenting of the OM2. And after that, what we found is after a stenting, there was a plaque shift, and then we went ahead and extended the stent proximally, and this was the final result in the OM2. And then we did a bifurcation stenting to the LAD diagonal stenosis, because this was kissing stents, because the LAD and diagonal were both big-sized vessels. And this is the final result which we got. And this patient did very well. The total amount of contrast used was only 90 ml, because we used proximal protection and we worked on the roadmap. And the patient the ST settled. There was no permanent damage. The TIA settled, and the patient was discharged on the second post-operative day. So this is one case which I showed. It was interesting because this was both acute coronary syndrome and acute cerebrovascular event. We used proximal protection through a radial route in a difficult arch anatomy. The patient, we did bilateral carotid, which is against the normal teaching, and we also did a bilateral, 2-vessel bifurcation stenting.
Dr. Khanna, congratulations on a presentation of an excellent case. But pardon my ignorance, I would like to ask 2 questions.
Yeah.
When the acute coronary syndrome is there, the myocardium is at a stake. Why did you not tackle the coronary first and you went to the carotid? And another thing is, even while putting the distal protection device, sometimes there could be embolization. You can have convulsions or some CA can occur. Luckily, your patient and you both were lucky, so you could overcome that and you didn't have any problem. And usually both the carotids are not tackled in the same sitting. So what are your comments and the messages to the audience?
That's what I said. This is not the usual way we do it. Now let's answer your second question first. We are not concerned. If we use a distal protection, then there was a problem, because we could have embolized. That's why we used a proximal protection. Once you establish a proximal protection, that means you are reversing the flow from the intracranial circulation down to the common carotid artery and into the aorta. So there is no risk of distal embolization, and that's why proximal protection was used, unlike distal protection. Distal protection would have been very dangerous in this patient. Now, normally we do not do bilateral carotids together because of the risk of hyperperfusion syndrome in the brain and the risk of bleeding. But if you have a patient who is having TIAs on the table in spite of correcting one internal carotid artery stenosis, and also this patient was not hypertensive, the risk of hyperperfusion syndrome was quite low, and that's why we went ahead and did it. And that's why I said this is not a usual teaching, but this was one case where we did it, and that was at 2 o'clock in the night. And coronary, of course, we had to sort of go ahead and do, because the patient was having acute coronary syndrome. And it's a practice where you can do carotid first or coronary first, it doesn't matter. But actually, if the patient is having ischemia in the brain and also ischemia in the coronaries, and is stable hemodynamically but he's having crescendo TIAs, it is better to fix the brain first, because if you have an infarct in the interim period, then there is a problem and the patient may actually land up with a lot of complications later on, which are difficult to treat.
Okay.
So these are the two, these are the answers for all your three questions.
Yeah, we'll.
Very nice presentation, very nice case, and 2 a.m. you did a fantastic job. Can you tell us what you did with the con meds, and how was your what kind of post-operative or post-procedure medications you'll recommend for the audience, so that you can help to prevent the restenosis and manage the case?
The patient was on usual dual antiplatelet treatment, and he had a normal heparinization with an ACT between 250 to 300. We do not use GP2B3A receptor antagonist in patients where we are treating carotid artery stenosis and coronaries together, because of the risk of cerebral bleeding and hyperperfusion syndrome. The restenosis is not an issue in carotids, because these are big vessels. They are of the size of 6 to 7 millimeter in diameter, and restenosis is not a problem there. Actually, we leave residual stenosis of 10 to 20% in most of the cases, because our aim is to only cover the plaque and prevent embolization. And even if there is a restenosis, it doesn't matter, because there are 3 other arteries to take care of cerebral circulation, but it's very rare. Okay. Now, restenosis in terms of coronary artery disease, we use Zyme stents. The risk of restenosis was minimum with Zyme stents, as per the evidence we have for all the 3 drug-eluting stents which are FDA approved. And secondly, we did adequate pre-dilatation and post-dilatation, so we had no residual stenosis. The stent apposition was fine. That's why this was the only thing we could do to prevent a restenosis, and now we have a follow-up of about 2 years. There is no restenosis in this patient. We have done a check angiogram.
Thank you, Professor Khanna.
Very
Please
nice.
move ahead with your second presentation that we have. Professor Khanna, please.
Okay. So this is another unusual case of left main coronary artery embolization, and this is a patient who underwent PTCA with stent to proximal LED in another hospital, in a small district hospital. And 2 months post-stenting, he presented with unstable angina and fever. And the coronary angiogram done that time revealed an aneurysm, which was a mycotic aneurysm at the proximal edge of the stent, and there was a proximal LED stenosis. Then this patient underwent surgery. The stent was removed, and the aneurysm was repaired and resected with a Dacron patch. And the patient also had a bypass graft. The surgeons were smart enough, and they did a bypass graft to LED and did a bypass graft to OM, and thought that the problem was over. But in the post-operative period, around 1 month, the patient developed sternal dehiscence and continued to be having fever. He was on antibiotics and had resuturing, but it didn't help him. And suddenly one day he presented with recurrent and massive hemoptysis. The CT angiogram revealed there was a massive rupture of the pseudoaneurysm of the left main coronary artery, and this was because this aneurysm was eroding and communicating into the lingular lobe bronchus, and also there was a compression of the of the saphenous vein graft to the LAD. You can see the CT angio here, and what you see is there is a huge pseudoaneurysm arising from the left main, and if you see it on the left side, there is a large amount of collection in the thorax, and patient presented with a large hemothorax and a huge pseudoaneurysm, almost covering the entire chest on the left side. This is the reconstructed 3D image on a CT angiogram. You can see there's a tenting of the saphenous vein graft to the LAD, and there's a huge aneurysm from the left main. I think Dr. Bera is here. He was the one who did this CT angio when he was in our hospital. And here, clearly, the surgeons did not want to go in again, because the sternum was infected, the pseudoaneurysm was ruptured and was holding on because of the surrounding blood. The patient was very critical and in condition and in shock, and the surgeons clearly did not want to do anything and referred the patient to us. And this is what we saw. There was a pseudoaneurysm in the left main. This is only an angiogram or the luminogram of the left main, but the aneurysm, as you see on the CT, was huge. It was almost like 5 to 6 centimeter. So our only option here was that we can't do anything, let's stop the bleeding and let's thrombose this aneurysm. And there were two choices. We could have shoved in coils and it would have required at least 60 to 70 coils to cover this, to actually fill this aneurysm. So what we did is we first checked the coronary arteries and the grafts, and here you can see because of the aneurysm, the graft to the LED is sort of tented up and there is a stenosis, pseudostenosis because of external compression in the graft to LED. And this is the graft to OM, which is normal. And this is a huge pseudoaneurysm. So what we did, we went with a 6 French guiding catheter and we hooked the left main and we went into the aneurysm and then put in a 014 guide wire and passed in a 4 French diagnostic catheter through this 6 French guiding catheter. And through this we delivered coils. These are 052 coils, which we, 035 coils, which are 5 to 8 millimeter in diameter, but we could see all of them were sort of floating in the aneurysm because it was too big. So what we thought, let's go ahead and then embolize the left main because the coronaries are already protected by the graft, and we put in 4 coils into the left main and could achieve a total occlusion of the left main. And then we went ahead with the same catheter and injected thrombin into the pseudoaneurysm. And we waited for about 15 minutes on the table. We reconfirmed there was no flow in the pseudoaneurysm, both by coronary angio and also by thoracic echocardiography. The hemodynamics improved. Hemoptysis stopped immediately. The IOBP support was withdrawn on the 3rd post-op day. The patient was discharged on the 6th post-op day. On the follow-up, we found that the venous graft to LED got decompressed because of the partial resolution of thrombus after successful sealing of aneurysm by embolization of the left main. So this is what we did. I believe this is one of the rare cases where the left main was embolized in a patient, and that too in a mycotic aneurysm, and the patient actually did well. The hemoptysis was controlled and the patient did not develop any fever after that, and he was on long-term parenteral antibiotics for about 2 months, and we've got a follow-up of more than a year now.
This is indeed an incredible case. And just, they say hindsight is 20/20. Is there anything you would recommend that could have been done differently or that you would add the first time around in case you see another patient like that? Or if one of us in the audience sees another case like this?
There are two things. One, now we have better plugs. We could have put a plug there and sealed it off with one device. That was one. The other thing which, in the hindsight, which I want to give as a message is, these pseudoaneurysms and mycotic aneurysms do not happen very commonly. They happen because of poor sterility in the cath lab. And if we do angioplasties in small cath labs, one should be very careful of not reusing the guiding caths and the wires, which we sometimes reuse in smaller centers. And that is the cause of this disaster. So this is just a take-home message that whenever you are dealing with coronaries and putting stents, one should always be very careful of the sterility and try not to reuse guiding catheters and guide wires.
Okay.
Excellent presentation and the case. Dr. M.J. Gandhi or anyone, any comment or question?
Okay, no.
Yeah, please.
You have used the word poor sterility. Thing is either sterile or unsterile. What is poor sterility, sterilized and rich sterility? I do not know that. I think let us be very clear about it. And such a serious heart problem, sterility should be sterile means perfectly sterile. And poor and rich is not the terms to be used, I think.
Yeah, but these are the things, in India, a lot of centers, even big centers, would reuse devices, reuse the guiding catheters and guide wires, and sometimes these sort of complications do arise. So one has to be careful, and there's a lot of price which the patient paid for this, and these are totally avoidable problems. Fixing is not a big problem, but it was just to show that these sort of things can happen. The patient had one stent removal, one surgery, almost died because of sternal dehiscence. he had hemothorax, and then we finally ended up with embolization of the left main.
Okay. Thank you, Professor.